right, well, welcome everybody. I hope you hear me okay. Thank you for coming this evening to be here with us. If you survived the second day of ASCO, my prediction is you're going to survive the rest of it. So I'm glad you're here. And we're really excited. We have a great program tonight, and it's all about melanoma. We're going to focus on multiple different lines of therapy in melanoma, and we're going to talk about moving the efficacy needle and how important immunotherapy is. We'll talk about modern standards and next generation strategies in both resectable and unresectable disease. My name is Tawbi. I'm a professor and deputy chair in the Department of Melanoma Medical Oncology at MD Anderson Cancer Center. I also co-direct the Andrew McDougall Brain Metastases Clinic and Research Program. I'm joined tonight by Professor Paolo Ascierto, who is the leader of the melanoma department at the Istituto Tumori in Napoli, and also the phase 1 program, and really one of the absolute stars in melanoma. And I consider him a true role model and a mentor to me personally. So thank you for joining us, Professor Ascierto. We also have Dr. Isabella Glitza from MD Anderson, who is a professor at the Department of Melanoma Medical Oncology at MD Anderson. And I can tell you, one of the bravest people I know. She is the director of our intrathecal and LMD program at MD Anderson. So she treats literally the hardest patients with melanoma. I have to send my patients to her when I get scared. So this is Dr. Glitza, and we're really happy to have her here with us as well. And she's going to discuss multiple different lines of therapy. So for tonight, again, this is the three of us. Thank you to PeerView and AIM at Melanoma Foundation and AIM with Immunotherapy for providing this session. Bristol Myers Squibb and Iovance Biotherapeutics have provided the educational grants for this symposium. And you probably already have seen the pre-event survey. You're going to be asked to participate, whether you like it or not. You're going to be involved tonight, and you're going to be polling some things. In fact, there's going to be question and answers, and the polls, as you will see, will have a QR code that you could use to do polls, and there's a very sweet to sweeten the deal for you. If you ask enough questions, you could be the winner tonight and take home a $50 gift card. Who knew? So I think you can be really involved, but honestly, if you want to use the QR code and use this, that's fine, but you could also just raise your hand or throw something at us, and we'll be happy to answer questions from you. And this is some of the enduring materials. So there's going to be some slides and practice aids that will be available for you as well in the future. So I told you there will be polls. We'll start with one. So as you think through today's presentations, we want you to take a few minutes and reflect on your practice and tell us, what is the option that you think represents a true challenge or ongoing question in your current management of patients with either resectable or unresectable melanoma? Is it choosing effective and tolerable immunotherapy in elderly patients? Is it the optimal sequencing in BRAF mutated patients? What to do when patients progress on immunotherapy? Familiarity with the newer mechanisms of actions that we have in metastatic disease. Figuring out who you should treat in stage 2 with adjuvant immunotherapy, or even the role of immunotherapy combinations in both adjuvant or neoadjuvant therapy. Or is it choosing an immunotherapy option in the neoadjuvant setting, or all of the above? So please feel free to answer here. And again, this will help us tailor our presentations and answer some of your questions and help you improve your familiarity with the data so that you could treat your patients in the best possible way. I was told we could wrap here. Is this when I get to wrap? No. Okay. How long does this take, the polling? 8 seconds. Get your answers in. Did we lose power? This happens in Houston a lot because of our thunderstorms. Okay. All of the above. So I like those. I mean, half of you answered that, and I think great, because we're going to address each and every one of those issues along the way today, and we'll be helping you kind of get some of the information to help your practice as well. All right. Can we move on? My forward button's not working. All right, and so again, this is sponsored by AIM at Melanoma, and both the AIM with Immunotherapy Foundation and the AIM at Melanoma Foundation. And tonight, if you don't have other plans, we can tell you that there's going to be a really great gala in the memory of Val Gild, who established the AIM Foundation, from 7 to 11 p.m. And here's a QR code also to register for that. Kelly said that she might even provide transportation. No, just kidding. So, so again, we're going to start now with the reinforcing immunotherapy principles, specifically focusing on frontline combinations, T-cell therapy, and emerging approaches. And I will turn it over to Dr. Glitza.
Thank you, Dr. Tawbi. And welcome, everybody. So I think we'll have a very exciting program tonight. And again, I think feel free. This is supposed to be interactive. We can't claim, the three of us, that we know everything, but we do know between the three of us a lot. So if we can help take care of your patients in a better way, I think this is the goal for tonight. So the way that we wanted to do this is really just providing you with some examples of patient examples that we do see in our practice. And you will see not great variations, but you will see, and one of the questions online was already about, do we take age into consideration? Do we take the BRAF mutation into consideration? So one part of my talk will actually address this part. How do we potentially manage an older, more frail patient? How do we take BRAF mutation into our treatment paradigm? And so again, this is a 65-year-old, overall doing good performance status. Really, comorbidities, I would say, are not really very exciting. Hyperlipidemia, you will have this after tonight's dinner anyway, at least transiently. Patient with GERD, former smoker, again, not really something that I would say, is something that is a red flag. But now to his melanoma history. So you can see written that there are multiple lymph nodes, there's lung metastases, the LDH is normal, which again, remember, this is a thing that we look, and you will see in every trial, this LDH is one of the different aspects we look. This particular patient is wild type and has no brain metastases. So maybe I'll start off with Dr. Tawbi. So again, pretty healthy 65-year-old, right? 60s is the new 50s. So what are your thoughts on maybe using first-line therapy in this patient? Would you go single agent, combination? And if you choose combination, wink, would you go with, combination CTLA-4 and PD-1, or would you go with PD-1 and LAG-3? Just maybe your thoughts.
Yeah, I mean, it's interesting. I stopped using single-agent PD-1 on March 19th of 2022 because that was the date that Nivorala got FDA approved, and there's phase 3 randomized double-blinded evidence that combinations are more effective than single-agent. So I do occasionally use single-agents. We'll get to and later today in very unique situations where I just really can't afford some of the toxicities, and we can talk through this. So I always choose dual checkpoint inhibitors for patients like this. I don't immediately think, can they handle the high toxicity regimen, and therefore I treat them with the toxicity regimen. I think more specifically, and I'm not sure what's happening with my mic.
It's
not working.
Am I sitting on it?
You might have gotten disconnected.
I'm sorry.
Okay.
But
Can you hear me now?
Yep, we can.
All right, so I focus on what's going to be most efficacious for the patient. The goal is to give them, the highest chance of a cure. So I feel that combination checkpoint blockade makes the most sense. But I'll pass it to Paulo in terms of which combination he chooses.
Yeah, so I agree with you, Hussein. And this is a good case, I would say, because just two sites, lung and lymph node, that in general, the good sites, if we can say good site, normal LDH. So in Italy, we have a particular situation because we cannot use combination PD-L1 positive. So PD-L1 for us, it's important. But I totally agree with you. In this case, still I would prefer combination, and probably Nivorella is, from my point of view, the better option because looking to the data, the comparison data between EP and NIVO, the 067, 047, and also the safety profile mainly. So I would go in this case for a better safety profile. Combination, but more
So-
safe.
So thank you both. And I think what you will hear that really, again, no patient is the same. We look at each patient as their own individual human being, again, that come with comorbidities, performance status, risk factors, but also always have to contrast this with the toxicity profile. So now we have an 80-year-old patient who is not so fit, so performance status of 2. Again, remember that is not a very crispy 80-year-old, right? So performance status 2 is there is definitely some decline, not able to potentially do all the activities of daily living. Again, similar cancer profile though. So again, Hussein, just because you mentioned how actually safe and wonderful this is and that you really stopped using single agent, would you still consider dual combination in this gentleman?
Yeah, well, I mean, again, the efficacy data, and our patients are coming to us to be cured of their cancer. So, and even an 80-year-old, you could really cure. If you can't cure them, their life expectancy would be a couple of years. If you do, they could. If you can cure them, they could live a normal span of life. So, from my perspective, giving them the most efficacious thing I can is combination. In this case, I would heavily favor the safer combination, of course, over Ipi-Nivo, which is a little bit harder. So I would also do PD-1 LAG-3 in this setting.
Great, and I promise I'll go briefly through the data for Nivo-Rela in a second, both for the PFS and the overall survival. So now we're switching it up a little bit. So again, same patient, again, youngish, it's youngish, 65 is still youngish, but this time BRAF mutated, no brain metastases. So now we're obviously adding a potential other whole treatment option to this mix, right? So we're talking now about BRAF inhibitors. What would you do, Paolo? Just again, well, how would you counsel your patient? And I know we'll go through the data, but what would you?
So this was one of the classical questions at the beginning of the story of target therapy in checkpoint inhibitors, to be or not to be, target or immunotherapy. But now we have the data that you will show very soon.
Correct.
And so still, I prefer immunotherapies first. Why? Because if we start with target therapy, and in case of progression, we know that in a high number of patients, we have progression. Just the 20% of patients may have a tail, even less. But in case of progression, the resistance to target therapy affect also response to immunotherapy. So it's clear from the data now that immunotherapy should be started first, except for some cases that probably we'll discuss later.
And while everybody's in the room is at least somewhat either a melanoma expert or works in melanoma or interested, I think it's an incredible reminder that 14 years after Yervoy or Ipi was FDA approved, the amount of questions that we've been able to answer for our patients and really move the needle forward. And the final patient is, and maybe I'll just do quickly through just for the sake of time. Again, we have a 65-year-old, again, same comorbidities, a little bit more frail maybe, is BRAF mutated and has asymptomatic brain mets when we did the scan by imaging, so didn't come in with a limp or with signs that are suggestive neurological for brain metastases. And again, the question, and I'm going to try to answer this during the presentation, there's also already an online question about in the patients who are BRAF mutated, when do we actually start with BRAF inhibitors versus not? And again, what would be the strategy, single agent or combination? And I think the key takeaway, if you really all fall into a postprandial sleep, is that I think there is really very limited to no role for single agent checkpoint inhibitors for patients with active brain metastases. It is the combination. We'll show you also some emerging data for PD-1 and LAG-3, but I think the key takeaways, again, immunotherapy takes the win, the lead, and it is the combination that is an absolute must. So let's kind of go through the data. And again, combination immunotherapy. Now, thinking back about our initial patient presentation, that was the 65-year-old but healthy, really just overall limited diseases. Paolo just said, just lung and lymph nodes, favorable profile. So you can see that in the NCCN guidelines, the combination checkpoint blockade is preferred. And as Hussein earlier, when we were talking about the slides, pointed out, It is the preferred regimen within the preferred regimen section. So again, I think, again, having to answer the question, if we can, unless there's really a true contraindication, I would say, again, combination checkpoint for patients coming through the door is the preferred regimen. And we have two, and you'll hear us talk about the differences with PD-1 LAG-3 side effects, which is very, very favorable compared to Ipi/Nivo. However, again, I think there are situations where Ipi/Nivo is maybe a must, to paraphrase it. But again, these are the current guidelines based on the most recent version from 2025. Now, I promised you we'll go briefly over the Nivo-Rela data. So again, this is the Relativity 047. And again, I'm in wonderful company because, as you can see, that Hussein presented this multiple times or multiple updates, and there's more coming. But again, as you can see, the 3-year data, the PFS benefit from, look at the blue line, this is the Nivo-Rela combination versus Nivo. At 48 months, the difference was 30 versus 22%. And again, what I think is so amazing about this data, again, that we had over 700 patients enrolled, right? So this is a huge study, which we have full confidence in the data. And I think we all have seen this pan out in our clinical practice, that this is a wonderful combination, even for patients that are old and frail. Now, we created, obviously, the cases with also trying to educate and create really some highlights. And so we had both the older patient that was over 80. We also had the BRAF mutated patients that we've thrown in there. And again, forget still the brain mets. So this is really just the first 2 cases. And you can see that this efficacy benefit, and it might be a little bit small for you to read, but all the plots to the left is actually Nivo-Rela benefit versus to the right is Nivo single agent. So you can see, even though we highlighted specifically H and BRAF in this case, because again, these were the 2 patients that walked into our clinic on a Monday morning, that this benefit really consistently carries through with a combination of Nivo-Rela. And again, we also now have overall survival data, again presented by Hussein at last year's ASCO, that really not only translated this PFS benefit, but also the overall survival. And you can see 5-year data now available, which again is exciting as an oncologist who started off in melanoma with just Ipi, to really see that we now have 5-year overall survival of close to 50% for this combination. Again, I think this used to be unheard of, right? We used to say 10-15% of patients alive at 1 year without brain mets. And so again, unparalleled data. Also, something we like to look at too is the melanoma-specific survival. And again, we can see the same trend for Nivo-Rela. This is, again, data for the 48-month, 4-year mark. And again, you can see 60% versus 50% for the combination. And again, hazard ratio 0.75. You can see, again, the non-melanoma deaths and what they were kind of other lumped together. But I think very convincing data that the combination wins, if we actually want to call it a win. But again, it's when we call, I think, in oncology a win, we really mean a win for our patients and how we manage them and give them better outcomes to be with their loved ones. So now let's switch. So now we have the question about, we have a patient with BRAF mutated melanoma. And there is one question online, and maybe we can just quickly debate this. Would it be okay to start the patient on immunotherapy combination up front without knowing the BRAF mutation status? And I think it is okay, because I will show you 2 studies. One, again, was led by my dear colleague, Dr. Ascierto here, but there are no really good solid data from 2 studies. The first one is the DREAM-seq, again, showing superiority of the overall survival in patients. Again, these are all BRAF mutated, when we started patients with double checkpoint inhibition versus BRAF mutation, BRAF inhibitor. So we used Ipi/Nivo, and then followed versus dabrafenib trametinib at progression versus dabrafenib trametinib followed by Ipi/Nivo. And again, you can see the overall survival curves, which are really, I don't think I have to convince you that the upfront immunotherapy combination did significantly better. And again, there is a follow-up that is now being presented at this year's ASCO. So again, nearly 5-year median follow-up. Again, we're getting really this long-term exciting data. And patients always ask, is there a chance to live long? I typically don't use the word cure, but can I live with this, Dr. Glitza? And I said, yes, we have data that really shows you can survive this. You can be cancer-free. You can be treatment-free. and just have a normal life and hopefully forget about your melanoma. But again, what you can see, near doubling, 30% absolute difference. Again, these are real differences in lives, in a 5-year overall survival and a tripling of the 5-year PFS. And again, this is kind of the quick summary. Again, I already alluded to the fact that, again, Dr. Ascierto really led this fantastic other clinical trial called the Succumbit. And again, we have 5-year data now. And this was a triplet, 3-arm trial. So again, what we saw is we had one arm using Encobini upfront, and then at progression switching over to Ipi/Nivo. The second arm, arm B, was Ipi/Nivo, and then at progression you would switch over to Encobini. And then the third, arm C, which you will hear me talk a little bit about more also in the brain met section, had a planned switch. So you start with Encobini, but you don't continue until the patients progress, and that's really the key important. It's kind of like an induction period. You do this for 8 weeks, roughly, and then you plan to switch them over to Ipi/Nivo. So again, I think we all scan at this point, but we expect a good response, and then we still switch those patients over, so we don't wait for the progression. And look at this again, we have 5-year data, right? 60 months progression-free survival. And again, you can see that both arms that have Ipi/Nivo early on, either upfront or with this, I'm going to call it forced or planned switch at 8 weeks, you can see that the 50% PFS at 5 years. And very similar data for the overall survival. So you can see, again, 52 and 57%. So again, clearly providing us key data that patients, again, have meaningful survival benefit with immunotherapy, with or without this 8-week induction targeted therapy. So now switching to something that, as Hussein already alluded, and we share, I think, the desire to really make a difference in patients with brain metastases. So let's talk about what happens in brain metastases. And again, if you forget everything from the last 15 minutes that I talked about, again, combination immunotherapy is what you want to use if you can use it, and it works incredible. And why do I say this? Historic data, as you remember, overall survival 4 months with brain metastases. This is in the dark ages, and really now we're looking at these durable benefits. You can see the waterfall plots here. You can see the amazing intracranial progression-free survival. And this was, again, the Checkmate 204, again, that Dr. Tawbi led with, I think, over 101 patients. I might confuse them, but over 100 patients, which, again, solid data in this patient population. And importantly, you have a clinical benefit rate of 57%, which is huge, right? And importantly, the majority of these patients continue to do well, and we have now longer overall survival, which I'm going to show you right now. So, and this is not, though, the only study, even though this was really a very, very large study. And again, I have to applaud Hussein for really running this and getting us the data. But there are really 3 studies when we talk about brain metastases in melanoma and immunotherapy that deserve some mention. Maybe a 4th that is just being published. But the NIBIT is Ipi/Nivo again. And you can see here at the 3-year, kind of on the left of the curve, a 48% survival at 3 years, right? Again, think the 4 months, right? So, I mean, now we have 3 years where 48% of patients are alive. The Australian group with Georgina Long published the ABC. It had 3 arms total, but again, this is a focus on the combination immunotherapy using Ipi/Nivo with 57%, again, at 3 years. And again, the Checkmate 204, 72% at 3 years. There is now a 7-year update for both the NIBIT and the ABC, and the numbers of overall survival are still in the mid to high 40s. So again, let this sink in, right? 7-year overall survival of over 40% with active brain metastases. You can tell I get really excited, but I think, again, we see these patients and we have hope. So now to the question of, again, we have this person coming in with BRAF-positive melanoma, brain metastases, asymptomatic. That was the description. Should we start him on targeted therapy? And again, as a quick reminder, the COMBI-MB using dabrafenib, trametinib was really a larger prospective study, had multiple cohorts, but again, the main focus on cohort A. The key message is these drugs work, no question about it. You can see the overall response rate close to 60%, but the duration of response is very limited, only 6.5 months. And this is, again, in stark contrast to the data that I just showed you with Ipi/Nivo. We have some data, again, from Dr. Ascierto's SECOMBIT study that looked specifically at the development of brain metastases. So the right side of the slide is now not really talking about patients with active brain metastases, it's the development of brain metastases. And as you can see, again, arm B and C, so starting with either upfront Ipi/Nivo or doing this short induction with targeted therapy, might even be protective against brain metastases, meaning this patients had a significantly less likelihood of developing brain metastases. And I think these are my last few slides for brain mets, and then we have just a few slides about toxicity and subcutaneous administration. But we also should mention a trial again that Dr. Tawbi is leading at MD Anderson called Bluebonnet. We live in Texas, so we use the national or the state flower. Again, this uses Nivorella for untreated brain metastases. And again, you can see regular dosing of the drug. We check already at 4 weeks the initial MRI to kind of gauge how things are going. And preliminary data presented last year showed an overall response rate of 44, slightly less than Ipi/Nivo, but again, super toxicity profile. And then what you see written below is the relativity 020, which is, again, in patients that are PD-1 refractory. So forget treatment naive. This is PD-1 refractory. Out of these many patients that were treated, and again, Dr. Ascierto will go over the response rate in the PD-1 refractory setting with Nivorella, which is, little spoiler, 12%. But for brain mets, out of these 27 patients that had brain mets, we actually did also see some responses, 22%. So to recap, again, combination immunotherapy supported by guidelines over single agents for patients that are either youngish, 65 and good performance status, or 80 and not so good performance status. And again, in the older patient, I definitely would go in with relativity 047 data doing Nivorella. And I think we could argue about, if this patient had liver metastases and maybe high LDH, the 65-year-old, would we maybe use Ipi/Nivo? I think these are nuances that are important, but I think for the general recommendation is combination. Again, for BRAF mutated patients, we like to go in still with immunotherapy, but BRAF MEK can be considered, especially in patients that are maybe highly symptomatic and need rapid tumor reduction. Again, as it said, it's an option. And again, in the setting of brain metastases, please remember Ipi/Nivo. So kind of going through the quick poll of the audience. So reconsider our 80-year-old patient with BRAF wild-type melanoma. Again, had lung and lymph nodes, performance status of 2. What's your first-line treatment choice? Make me proud, people. Make me proud. Aha. Some of you might be changing their choice after my little aha. So let's. Oh no! Somebody just clicked the wrong. No, there's really no wrong, but again, maybe not recommended. So again, there should be maybe mentioned that there's some data for Pembro and low-dose Ipi, but again, the combination is not FDA approved. So, but again, I think from a toxicity perspective, that's important.
And Bella, really great job presenting these. Maybe before we move on, I will bring up one of the questions that were asked from the audience, and I think it's very relevant to consider that what are the type of patients that you might recommend the SECOMBIT approach for? And I will highlight specifically one of the facts from the DreamSeq study is the fact that there was about 24 patients on the Ipi/Nivo arm, right, randomized to start with Ipi/Nivo. These are BRAF mutated patients that ended up progressing and dying before they received even targeted therapy. So got Ipi/Nivo up front, and they were so progressive that they ended up unfortunately not responding and not getting to BRAF targeted therapy. And I think that is exactly why our dear friend Dr. Ascierto chose to design the SECOMBIT study so that we can look at those populations. So Paolo, what are your thoughts?
Yeah, so the sandwich approach. Why sandwich? Because it was a short course of TKI and then the switch to immunotherapy, and again, in case of progression, TKI. We have seen in the SECOMBIT that the population where you have the maximum benefit and the population with elevated LDH, high tumor burden, as you mentioned. So these were the group where we found a better outcome. And this is the group of populations where we should use the sandwich approach.
And hopefully it's not a sandwich, but an open sandwich.
Yeah, open sandwich.
Right?
It's an open sandwich.
An open
correct.
sandwich, just with one egg on top.
I think they call it pizza in Napoli.
Yes. And then there was also a quick question online I'm seeing, Hussein, about the toxicity. So my fellows or residents that rotate with me, when I tell them, when they said, so give me a quick one-liner how to remember Ipi-Nivo versus, single agent. So I tell them a rule of 55. So please don't quote me. But the rule of 55 is you have about a 55% chance of responding in the body, treatment naive. You have about a 55% chance of responding in your brain. It's actually higher, but 55 is good. And you have about a 55% chance of grade 3, grade 4 toxicity. So just maybe answering this quickly for the audience. And again, what would we do again for patients with brain mets or very symptomatic ones? I think, again, this is where we use the pizza open sandwich approach in a BRAF mutated patients, especially if they're steroid dependent, right? We want to get them potentially off steroids. So we might want to do an induction, but not wait for 6, 9, 12 months, because I showed you the duration of response is limited to about 6.5 months. So you want to go in early, you want to monitor these carefully. But I know I'm running out of time and I don't want to be, I want to be invited back. So I'm going to just get through these next slides very quickly. So I think one important thing is now to note that nivolumab can be given subcutaneously, but it is really just for the PD-1 single agent part. So if you do the combination of Ipi-Nivo, it is still theoretically with the combination IV, and then you can switch over in the maintenance phase to the subcutaneous formulation. And I think that also should answer one of the online questions. And again, for relatlimab, it's all in the same bag. I actually tell this to my patient because, again, Dr. Ascierto will talk about the data of Nivorella in the post-PD-1 session. And so I tell them it comes into the same bag. It's 30 minutes. And again, there is now assessment of the relativity, or in the relativity 127 for assessing fixed dose subcutaneous Nivorella. And I think this is the final slide, though, is how do we manage and consider immune-related adverse events, or IRAEs. It's all about the grading. The grading will allow us to understand what we need to do in regards to management of the IRAE, holding it, permanently stopping steroids, what type, other immune modulatory agents. And again, most patients with grade 3 or grade 4 need to be hospitalized. And I think with this, I'll hand it over to my dear colleague and see what we do when the first lines don't work.
So there is the ambulance.
I know.
So it's, first of all, I'd like to thank you and the Purview for the kind invitation. This is an important topic because after immunotherapy frontline, after target therapy, then we have very few possibility or better. Probably now we have a little bit more, and we will see. So this is a new patients. Still 60-year-old patients with metastatic melanoma BRAF mutated. In the history, the patients was treated in first line with the combination of Ipi-Nivo, CTLA-4 PD-1, as second line the BRAF-MEK inhibitor, and then progression. The performance status was of 1 with a high tumor burden, so radiological progression after 3 months with an increasing LDH. So this is one of the classical patients that in general we have in front of us after the treatment, first line and second line with immunotherapy and target therapy. So we know that in US you have a second line the possibility to use the TILs, and but before to think to the TILs, another possibility may be the rechallenge. In the SECOMBIT, the rechallenge showed a difference between the total progression-free survival and overall survival. In overall survival is a little bit higher. Why this? Because with the rechallenge, we increased a little bit the survival. Having said that, what do you prefer, you said, as first?
Yeah, it's a tough question. I mean, first of all, I think I will go back and highlight the point that we don't have a lot of options for our PD-1 refractory patients. We're starting to see some, and we're very grateful that there's more trials in this setting. There were, almost a decade in which in every advisory board, you and I would sit and say, we don't have trials in the second line. So thankfully now we have a few, we have some activity. And I think, the one proven therapy now that is in our hands is cellular therapy with TIL. And Paolo will go over this, but TIL therapy is still logistically challenging. So you have to choose a patient that can undergo surgery and be able to be stable for a few weeks before you can treat them with the cellular therapy. So it ends up being a very specific patient population, and sometimes we don't have the luxury of that. So if our patients are progressing too rapidly, we have to resort to other approaches. One of them is re-challenge, but you will go through, once you show the data, how you could choose some of the patients' cellular therapy. Bella, any thoughts on that?
Yeah, I think the one thing that worries me, as much as TIL is obviously an option for this patient, the one line that it says, high tumor burden. And even though the patient is still having a good performance status, I think while we can set the patient up for TIL and get everything going, you definitely will need to have other therapies in between. And again, the question is specifically PD-1. I know you will show the data for Nivo-Rela, but also maybe even re-challenging with Ipi-Nivo. So we've done this before too. So
yes,
to see
we
the next slide.
will see the data about the second-line treatment with Ipi-Nivo and Nivo-Rela.
The one thing I'll say is TIL therapy, in some respects, has transformed the second line. I can tell you, our patients have more hope. Our patients come hoping to be able to be part of it. We have a bit more bravery, I would say, as physicians, to say, okay, maybe we can pursue TIL, but it's going to be requiring a little bit of this kind of bridging therapy that we start to think about, and that's where re-challenge could actually serve for that.
Maybe something of this. So, in case of TILs is chosen, how can clinician ensure the timely patients referral? Because as you say, these are patients with a very fast progression, and we will see that we need, of course, to get samples in order to get the TILs, and then we need time before the TILs. And as you say, we need the bridge therapy. And so what about, this process?
Yeah, well, I mean, I can tell you, to be a successful medical oncologist, you have to be at least friends with your surgeons. But to be a good at TIL therapy, you need to really make them happy and be very good friends with them, because having a setup where you have really great surgeons available to harvest the tissue and also be nice to your pathologist, also having pathology available to do it, I think is really critical. But time is a really critical factor for those patients in the PD-1 refractory space. You want to be able to get them through the process as quickly as possible. So it really requires a multidisciplinary team. And Bella and I are really lucky that we have a great team around us at MD Anderson. But you really have to work on making sure you have the right setup, and then you can get those patients in faster.
Bella, any additional
Yeah, I mean, I agree. I mean, that's where larger centers are just, I think, equipped to maybe act faster. But really, there's only so much we can do. And again, I'm looking at people maybe in the audience, because there is also one part that we can't fix. We can't fix and fix is maybe the wrong word. We cannot really expedite dramatically the production part of the TIL. It is a couple of weeks, and that's what we have to factor in again when we also talk to patients about TIL, because as Hussein said, a lot of our patients are obviously very excited, very eager to do TILs. But I think one thing that we as a community need to do better is really educate them about the different aspects, because a lot of them think they can just show up and get TILs. And it's their own cells. They need to first be harvested, and then they need to grow, and they need to live, and they need to live well and be angry and be able to kill the tumors. So I think we still really, and this is on all of us, to educate patients better about the steps to actually get it for them.
And in this group of patients, clinical trial is always the best option. For your point of view, which is at the moment one of the, a category of drugs that may be of interest for this group of patients?
Hard to choose, honestly, because we have several interesting agents. We have cytokines coming along. We have T-cell engagers. There's some of the injectable therapies, which I think you might answer. So it's an active space, and we're happy for our patients for that because we really need options in that space.
Do you believe that ADC as bridge treatment may be something of interest?
So the only thing I would say with ADCs or anything, right, I've always feel that clinical trials can be, but should not be used only as bridge because you might take the patient off too fast and you want to learn, right? So I feel I love the idea of a clinical trial, but then I would like to commit the patient after discussion to the trial to really also see if we can get maximum benefit, but not just giving 1 or 2 doses and then do TIL. So that would be my only.
We promised to engage the audience, and I think we have a question there.
How long does it take for this TIL to get ready? And then once it's ready, does it have a shelf life? So if the patient were to get sick a day before they're supposed to be getting this infusion, does it survive or not?
So what I would recommend is we'll let Dr. Ascierto go through his slides. He has a slide around the logistics, and then we can get back to your questions. It's a very good question, and those are things we need to think about.
It's a crucial
about
question.
Yeah. So go ahead, Paolo.
So one of the options that we discussed is the rechallenge. So and when we talk about the rechallenge, we talk about the possible combination ipi-nivo, because in general, when we use target therapy in the middle, we can reuse ipi-nivo or nivorela. We have studies that were done in the patients who were previously treated with an anti-PD-L1, PD-1 treatment, and looking the response rate in the SWOG 1601, as you can see, ipi-nivo showed 28% of response compared to the 9% of ipi alone, while nivorela in the 020 study in the cohort of patients previously treated showed that 12% in the cohort D1 and 9% D2. So looking to this data, of course, as a rechallenge, ipi-nivo seems to be better than nivorela, but these are the data. Of course, sometimes in patients who are treated with ipi-nivo, may be better to use nivorela as a rechallenge, but these are the data that you should consider when treat patients. There is another study in the patients who failed previous treatment with anti-PD-1, the study from the Dutch friend with the TILs compared to ipilimumab alone. And as you can see, looking to the progression-free survival, the patients treated with the TIL went better than the patients treated with ipilimumab alone. So looking to the guideline, as you can see, that the TILs are included in the treatment of patients who fail a previous treatment with anti-PD-1. Of course, what will be important, as Eugene and Bella highlight, it's, of course, to select really the patients, because the process is not easy. And we will see just in this slide, because what we need is first to get the samples, and then the samples should be sent to the laboratory, and then in the laboratory we should harvest the TILs, and then the TILs should grow, and then should be sent back to the site. And after this, we need as first to treat with lymphodepletion chemotherapy, and just after this, we can treat the patients with the TILs lifilocell, in this case, together high dosage of IL-245D. So it's not an easy process, need time, need several different steps, and for this reason it's important and crucial to define the right patients to treat. And anyway, with the TILs, we got very interesting data and response in the trial that we know that brought to the approval of TILs in second line. And as you can see, still in the patients who failed previous treatment with immunotherapy at 4 years. And in the next days, there will be an update at 5 years of the study. You can see an interesting trail in these patients of about 20%. That it's not so low, consider the patients with the resistance to previous anti-PD-1, PD-L1 treatment. Last year, we have seen here at ASCO also a study with the combination of TILs with pembrolizumab. At the moment is ongoing a phase 3 study which compared this approach to anti-PD-1 monotherapy. And coming back to what we have said about the practical use of TILs, it's important patient selection. It's important operational consideration, as we have seen, and of course the safety monitoring, because during the chemotherapy lymphoablative, we can have also, toxicity. It's important to avoid infection to these patients. And again, after the TIL infusion with high dose of IL-2, it's a treatment that it's very well known, but still we have a high toxicity, and in general is just the CRS or the fever and all this. There is another approach, as Hussein anticipated, the combination with oncolytic virus, in this case the RP1. RP1 is an herpes virus modified with the GM-CSF gene, and it was used in a study, the IGNITE-2, in combination with nivolumab, and the response rate was really nice. Still, for this group of patients, was more than 30%, with an interesting survival. At the moment is ongoing phase 3 study in this group of patients resistant to immunotherapy. So, as a recap for these patients, TILs are now approved, and it's surely an option, and it's included in the guideline. It's important, of course, to consider the clinical trials. We discussed there are new BRAF and MEK inhibitor at the moment that could be also useful in these patients. We have a trial with oncolytic virus, and still the rechallenge can be considered for this group of patients. Now, the pool. So consider these patients with metastatic BRAF mutated melanoma who progressed after both nivolumab and ipilimumab and BRAF MEK inhibitor. Which of the following would be the most likely considered next? First, clinical trial. 2, rechallenge with immune checkpoint inhibitor. 3, TIL therapy. 4, high dose IL-2. 5, I'm not sure what to do in this scenario. Please vote. So, the majority is for TIL. Interesting.
Yeah, there are some brave souls that want to do high-dose IL-2, which was, I mean, to be fair, it was a treatment option that was FDA approved, and it does, give long-term benefit to a very small subset of patients. But you could do high-dose IL-2 with TIL. That's what you do anyway. So maybe think about that. Paolo, do you want to address the question about what do you do if a patient gets sick as you're treating with, or you're planning to treat them with TIL, and you have that issue that our audience member brought up?
Yeah, so as first, you have to contact the surgeon, and you have to book the surgeon for the biopsy. And of course, this should be sent to the labs. After this, they take 3 weeks, more or less.
Yeah, somewhere between 3 and 6, depending. I mean, hopefully the time is supposed
the time,
to
the samples,
shrink.
how many lymphocytes there are. And after this, you receive back the cells. When you receive the cells, you cannot treat the patients the day after. Of course, you need as first to treat the patients with lymphodepletion chemotherapy. And after this, the infusion is after 3 days and of the tails, and you start high-dose IL-2 that you will continue for 5 days. So
Yeah,
the process is something like 5 weeks, maybe.
We say 10 to 12, actually, sometimes.
yeah.
So
10
it
to
dep-
12.
So it depends,
From
right?
start to finish. If
From
you start
start-
counting
from
talk- biopsy.
surgery, correct. From surgery to treatment.
So it's not short period, and of course, patients with a very fast disease, you cannot wait all of this.
And the goal is harvest to treat, not to basically cryopreserve and wait. So ideally, you should treat as quickly as you can. And obviously, if patients do deteriorate, you have to wonder if they're going to be able to handle the lymphodepletion, the infusion, and the high-dose IL-2. So, it is possible that we may lose patients in that period of time, which is why you have to select patients that could actually, be sustained during that period. And why Dr. Glitza is also bringing up the bridging therapy. Sometimes we even use chemotherapy to bridge, different things that can handle it.
But I think what's important, and I think that I would recommend for any center who does or which does TIL, is we discuss every patient in a multidisciplinary conference with everybody present and sign off. So I think this is a internal way, because we all get very attached to our patients, and I think sometimes we hope also that TIL might help them, but realistically it might not be the best option for the patient when you take your emotions out of it, where you step back. And I think that's where the collegial discussions about, is this a good candidate or not, or should we actually try to do something else, and then TIL might come up. And we've had actually a couple of patients that were deemed to maybe not be a good candidate in that very moment, but then with miraculously working therapies in between, the patient actually got to a place where they were able to get TIL. So again, I think you'll just have to really be transparent to your patients too, that you don't want to harm them, right? Because everything that we do to them can harm them to a degree.
Okay.
Absolutely.
Now is
Thank
the
you
time
so
for the
much.
adjuvant.
And then we're going to switch gears. So we talked about first-line management of patients, whether they're BRAF mutated or not. We talked about how to handle the second line. And now we're going to switch to the earlier settings in melanoma, and we'll discuss both the use of adjuvant and neoadjuvant therapy. And we'll start also with a case, and we'll start with a stage 2C patient. So a 59-year-old, we determined this lady's Alicia, has a T4B ulcerated melanoma, so head and neck melanoma, in this case specifically of the neck. Clinically does not have any enlarged lymph nodes. On pathology, you get an ulcerated deep lesion, so 4.2 millimeters. If you look at melanoma staging, once you go above 4, it's basically the high, like we stop counting. So 4 millimeter and above is really a very thick melanoma. In this case, by IHC, this is a BRAF wild type. The surgical management is a wide excision with sentinel lymph node biopsy, and in this case, the sentinel lymph node biopsy was negative. I note that she had 13 mitoses per millimeter square, which is a very high mitotic rate. Ideal mitotic rate for patients for melanoma is actually 0. You want to see 0 mitotic rate. So 0 to 1 is already considered quote unquote positive. Up to 10 is still relatively okay. More than 10, you're dealing with a high risk disease. So for a patient like this, what are the typical pathways that you guys go with? Do you go with adjuvant? Do you go with observation, Bella?
So I think both need to be discussed, right? So I think now we've moved away from brain mets and stage 4 disease or PD-1 refractory disease. I think any adjuvant discussion supplemented by the correct data needs to have an observation discussion as well, because again, this is not a patient that has for sure progressed. We are trying to decrease the risk of relapse. So I always mention observation even in stage 3C and 3D. I don't think I can be faulted for this. I might not spend a lot of time on it. And that's when the discussion comes in, how strongly do I recommend or offer therapy? But I think it needs to be brought up. Now, this is a 2C, and I believe you will show the risk of a 2C melanoma, which is actually pretty high. I think patients naturally, and I think oncologists even who don't treat melanoma often look at 2C and say, oh, but this is so much better than a stage 3. Well, it's not completely true, right? So when you look at the curves, and I see a lot of nods over there, it's really, you have to have this discussion that a 2C compared to a 3A is much, much worse, and that this might actually provide us some evidence that, again, adjuvant immunotherapy is the right choice, taking all things into consideration.
Great points. I mean, one of the very critical points that you're making, Bella, is the fact that those are patients that are, technically could be surgically cured, meaning that you could just do nothing, which is observation in this case, of course, not exactly nothing, but and they could be cured. So it's definitely an issue. So Paolo, how do you address the risk-benefit discussion in with those patients?
As Bella said, showing the patients the risk, and because the risk of the 2C is higher than the 3A, and it's more or less like the 3B. So it's a patient population that should do the adjuvant treatment. So our hope, our aim, our goal is to drive the patient decision. This is group of patients where we should recommend adjuvant.
So the factors that you take into consideration, I should mention, and we'll show the data. First is that we actually have effective adjuvant therapy. That's probably the most critical point here, that we can do something about it. Other factors you think?
Yeah, and I think there was a question online that I saw, what other factors or age are coming. And I think, again, this is a 2C, but maybe broadening the adjuvant discussion in general. I mean, if somebody is 95, I probably would just not do anything and just wish them well and see them regularly and hopefully just have some great stories about great grandchildren. I also think young females are a different subpopulation in regards to maybe fertility discussions that we have to have, or younger patients, again, that might develop, again, rare, but side effects that might limit their overall survival, like type 1 diabetes. Again, this is rare, but I think, again, I do take all these into account, and I try to bring them up during the discussion. So I do take age into account, both ends, if that makes sense, and then maybe patient's preference, and again, as I think you will briefly touch, also the reversibility of toxicities. Again, this is now not stage 2, so we're talking stage 1.
Let me ask you one question before.
Sorry.
I'm sorry, go ahead.
No, just a very short comment. In this case, one of the things that it's more and more in favor of adjuvant treatment is the number of mitosis. 13 is very high. So
Yes.
It's a really very high risk patient.
So we don't have this particular piece of data on the slides, but we actually ran an analysis between MD Anderson and the Melanoma Institute of Australia, and we showed that the risk of the higher the mitosis, the increased risk of not just relapse, but specifically brain metastases. Like, it's really interesting to be associated directly with that. Let me ask you a question to both of you. Assuming that you don't know the result of the sentinel lymph node biopsy yet, would you be surprised if this patient has a negative sentinel lymph node or not?
No.
I would be concerned, right? So, I mean, this is a patient that I would be highly nervous, because we also know that the head and neck is an area, like you mentioned, that has a higher risk for metastatic involvement and brain metastases, particularly the scalp. So I would be happy about the sentinel lymph node, but I would hold my breath until I have it.
Yeah, so that's really interesting, because I consider that my rule of thumb. Again, not published anywhere, don't quote me, but I basically say if a stage 2 patient, if a patient with a thick melanoma comes back with, and I expect them to have a positive sentinel lymph node, and they come back with a negative sentinel lymph node, those are the patients I treat with adjuvant. Because this patient with that much ulceration, deep and mitotic figures, you expect almost 65% of the time to have a positive sentinel lymph node. That's how high of a risk this population is. So would you do anything differently if this patient was BRAF mutated?
No.
No, because
No.
we cannot do.
Yes. No. That's a short
So
one.
going back to the data that I'll go over, in stage 2, we don't have any data for targeted therapy. So stage 2 is no approval for BRAF inhibitors in adjuvant therapy. Just remember that. So we have targeted therapy. So let's switch to this particular patient. I was clearly not surprised when the lymph node was positive this time, 1.2 centimeters. So it's kind of clinically detected on ultrasound, biopsy proven to be a positive sentinel lymph node. So you now have a stage 3B patient with a clinically detectable lymph node. If this patient undergoes resection, would you still consider immunotherapy as the standard of care if the patient was BRAF wild type?
Yes.
Yes.
3B, and you'll show the graph. So
Yeah.
yes.
So now there's a lymph node. Would you do combinations?
No. So again, I know we'll go through the data for stage 3, single agent versus combination. And again, I think highlighting that the combination might be more interesting in stage 4 resected disease, not stage 3. So again, throwing out some keywords for you all to remember when we check the final test. But again, as you are also going to allude, right, so the BRAF mutant disease will just open up the discussion to not only discuss single agents in a stage 3B patient, but also discuss targeted therapy as a adjuvant treatment option for this patient.
Right. So this brings us to, again, if it's a BRAF mutated melanoma, you do have the option in the stage 3 setting to do either PD-1 or BRAF. And those approvals are the same in Italy, correct? Yeah. All right. So again, what you will hear throughout the next, 10 or 15 minutes about adjuvant therapy, it is absolutely a discussion about risk. You are not treating active disease. You are treating someone whose tumor was surgically resected, technically could have the chance at surgical cure. And we know, as melanoma doctors, we fear primary melanomas because melanoma has the uncanny capacity to just metastasize, and they all do to a large degree. So you really have to think, how can I prevent metastases? How can I prevent my patients from developing metastatic disease? And from day one, your main job as a clinician is determining that risk of recurrence. Thankfully, we have a lot of data. In fact, the AJCC staging is based on solid data from 46,000 patients that were all treated. They were all patients that had sentinel lymph node biopsies done, so really solid data to give us a sense of where those patients stand. And we also know that there are other clinical pathologic features, not just what is in the AJCC staging, like mitotic rate is not actually part of the staging system. It fell out in a multivariable model, but it's still predictive. So recently, the MIA led the development of this tool that was actually also with multiple many sites, including MD Anderson. There was a validation cohort to it where they actually developed a few factors that were, it's a nomogram to a degree, but thankfully it's now also an online tool that you could just use to get a better assessment of your stage 2. But when I tell you stage 2 disease, and you heard all of us talk about how we look at that thick ulcerated melanoma and we fear it, this is no joke, because if you look at these data, these are actually from the AJCC that I was just talking about, the 46,000 patients. This is melanoma-specific survival. So every death you see on this curve is of their melanoma. And you see, obviously, we know that if you have stage 3D melanoma, you already have a 75% chance of dying of your disease. If you're stage 3B, the chance is, 3C, the chance is lower, but still really substantial. So, 60% survival from melanoma for stage 3C. And you tell me where 3B and 2C are. Those are superimposed curves. You can't separate them, right? Imagine 3B is what we just discussed, a situation where you have a 1.2 centimeter lymph node, and a 2C has negative sentinel lymph nodes, and yet the risk of death from melanoma is equivalent. So that is why we care so much about stage 2 patients, because we have a situation where you could actually you have a pretty high chance, again, in this case, up to 25% of dying of your melanoma. And importantly, we can do something about it, and that's the biggest issue here. So what we can do, you can see that in the guidelines now is very clear. Obviously, surgery first. Obviously, you can cure your patients with surgery. That's required, including assessment of the sentinel lymph nodes. But now, if you have a stage 2 disease, you could consider adjuvant treatment with PD-1 for patients with stage 2, specifically 2B and 2C. Again, 2A, maybe I should go back here and highlight that the stage 2A patients, or in this case, actually, we don't have the 2A on this graph, but 2A patients have a really excellent melanoma-specific survival, closer to 96%. So 2A, don't treat. 2B and above, you already are in the category of being worse than stage 3A and definitely about stage 3B. So the data that supports this in terms of the use of adjuvant PD-1 is from 2 different trials that were all ran, again, against placebo. So going back to what Dr. Glitza was saying, the fact that you can actually randomize to observation was perfectly appropriate because observation was the standard of care before these trials were ran. And it's still not a crazy thing to do because look at those placebo-treated patients. A lot of them, still did well long-term, so that's a good thing. But you could see that if you treat with a year of adjuvant pembrolizumab, you can decrease the risk of recurrence by 38%, and it's a highly statistically significant difference. So you could really decrease the risk by almost a third. And that's really important. That translates into distant metastases-free survival difference. You can't really pick out a single subgroup in which it's not effective. In most of these, as Bella explained to you in these forest plots, whenever you see things going to the left, in this case, they favor pembrolizumab as long as they don't cross that line in the middle. And even if you have a few that do cross the line, if you look at them, most of those are small cohorts. And because it's small, the confidence interval is bigger, and that's why you could cross that line. So still, generally speaking, the effect, the point estimate for almost every single one of those is that, square that's on the left, and it's in every single one of those subgroups beneficial in favor of pembrolizumab. We know that adjuvant nivolumab has been proven to do almost the same exact thing. I always tell my patients that Pembro and Nivo are identical. I can't see a difference between them except the administration schedule. And thankfully, the data supports my conclusions because look at that hazard ratio, 0.62 to the second decimal point. They're identical. So really the same benefit you get from Nivo versus, and in this case, Nivo versus placebo. And you see on the right the disease metastases-free survival. Again, if you look at the subgroup analysis with nivolumab, same thing. And they did try to do it in the 76K. They published a biomarker plus clinical pathologic data, trying to identify patients that, are markers that could help you choose. And the answer is really there's not a single factor that you can decide on. Really, the clinical risk remains the most important factor. So when you look at the current guidelines, if you have a patient who's stage 3, so this is stage 3 all the way from A to D, you see that PD-1 is a preferred option. You also have dabrafenib, trametinib. I'm not showing the data specifically here today, but the hazard ratio for dabrafenib, trametinib, and BRAF-mutated patients is also very comparable, if not slightly better. The hazard ratio against placebo is 0.52, and it's, again, in favor of dabrafenib and trametinib. If you have a clinically node-positive patient, again, we still have category 1 disease, but we're going to talk about potentially catching those patients before they go to surgery, and those will funnel to Dr. Ascierto to talk about the role of neoadjuvant therapy. But if they have clinically a positive disease and they've already been resected, those are patients that are appropriate to go to adjuvant therapy as well. Now, remember, there is a role for surgery in all patients with melanoma, and sometimes you can have melanoma patients that have a singular site of metastatic disease, like a singular lung met, or if you had a patient with, say, melanoma on their head and neck and they have an inguinal lymph node, it could be one lesion that is in the, one lesion in the lung. You can send your surgeon in and ask them to resect those tumors. And that happens. We have patients with a solitary brain metastasis. We treat them with gamma knife or surgery, and now they're free of disease. So you suddenly find yourself in melanoma with patients with stage 4, already proven metastatic disease that are now resected. What do you do with those patients? We always want to reach out to adjuvant therapies. I have to say that the adjuvant trials from BMS, the NIVO trials, have all included a resected stage 4 population. Some of the data, say, from targeted therapy did not. They did not include stage 4. But the German group ran the study on the left, which is the ImmuNet trial, and they specifically ran a randomized, double-blinded trial with patients with resected stage 4, and they said, we're going to observe some of them. Kudos to them. That was pretty brave. And we're going to treat, a third of them with Nivo alone and a third of them with high-dose Ipi-Nivo as combination in the adjuvant setting. So it's a very unique situation here. And if you look at the data, these three curves on the right and the left tell you a lot of information. One is if you don't treat, the risk of recurrence is 85%. So metastatic disease is metastatic, like you could get away with surgery, but in a few cases. Then single agent PD-1 actually gives you quite a bit of benefit. I mean, it's actually identical to the benefit of adjuvant therapy in stage 3. It's hazard ratio about 0.5. But if you treat with high dose Ipi-Nivo, the hazard ratio is almost 0.2. It's fascinating how effective. So that particular study affects my practice, and when I see patients with stage 4 resected disease, I reach out to high-dose Ipi-Nivo. But one thing for you to keep in mind, that's the only population you could do combination adjuvant therapy in, absolutely, because on the right, this is 1,800 patients worth of data to tell you that if you choose an unselected population of stage 3 or 4 patients and you treat with Ipi-Nivo, it was more toxic and not better than single-agent PD-1. That was Checkmate 915, which is why we do not recommend combination in the adjuvant therapy of stage 3. Only if it's a resection stage 4, it may make sense. And we just saw the early results from Relativity 098, where Nivo-Rela, we were excited that this is a safe combination, so maybe using it in the adjuvant setting would make sense. Compared to single-agent PD-1, we saw the press release telling us that that study, also a really large study, about 1,000 patients, was negative, showing that combination in the adjuvant setting was not better than single-agent. And you will see a deeper dive on the data on Tuesday in the melanoma oral session that Dr. Long will present. But in the adjuvant setting, we do have combinations that may be really exciting. Early days, we still don't know the full answers, but I'm sure you all have heard about the use of personalized personalized neoadjuvant therapy or individualized neoantigen therapy. That's the code word now. We don't call it a vaccine. It's INT. But essentially, this is based on taking the tumor tissue. So when you're treating a patient in the adjuvant setting, you actually have a little bit of time. Surgery has happened. Typically, in most of those trials, you have about 12 weeks before you can initiate adjuvant therapy. So in that period of time, you could sequence your patient's tumor, and you can, and in this particular case, what they did is they chose 34 neoantigens that they coded in a messenger RNA, and they injected into the patients at frequent intervals. And that, in combination with PD-1, didn't look very different in the first 8 to 12 months, but once you're past that 1 year of treatment, there was a really large difference in favor of the addition of the INT to pembrolizumab as opposed to pembrolizumab alone. This was a large difference. It was not in this particular study statistically significant, but it was enough to lead to a large phase 3 trial that's fully accrued and accrued very rapidly, and we're now waiting for the results. And that could be the next combination in the adjuvant setting. So to recap, again, if you have a stage 2 patient, we were just talking about the fact the risk is so high if it's a stage 2C that most of us on this stage would actually recommend treatment to patients because we feel like we can give them a significant benefit in terms of recurrence-free survival, DMFS, and hopefully eventually help them not have this recurrence. In stage 2B, the difference is about the same, but it's a situation where some of us may think the risk may not be high enough, but if the patient feels strongly about being treated, we could offer adjuvant therapy. And we make the distinction between offering treatment versus recommending treatment. So between saying you should do this versus if you really insist, fine, we can do it. Those are kind of slightly the two differences. And in the stage 2 population, knowing the BRAF mutation is always helpful, but we don't have the option of treating with BRAF inhibitors. If you're a stage 3 patient, you could do either BRAF inhibitors or single agent PD-1. And in general, no combination immunotherapy in the stage 3 setting. We're waiting to hear the results of maybe the INT vaccination, but do not use Ipi/Nivo in the stage 3 setting, only if you have a stage 4 patient. So let's talk about a scenario with a stage 2C resected melanoma, BRAF wild type. What would you counsel this patient to do and why? Remember, the more questions, the more likely you answer, the more likely you can get a $50 gift card. All right, great. And one of the questions from the audience was whether the worst prognosis from stage 2C versus 3A was reflective of unrecognized nodal involvement. And the answer is no, because sentinel lymph nodes, if done by experienced surgeons, is a very sensitive marker. So if you have a negative sentinel lymph node, that's basically what it is. So with that, I will turn it over to Dr. Ascierto, who's going to go through the neoadjuvant data. I may have clicked a slide. Okay, we're good.
Okay. We have another patient. We can call him Antonio, so an Italian patient. We have Lisa and now Antonio. Robert, it's Robert. So.
No.
It's Robert.
But in Italy, they call him Antonio.
Roberto.
No, Roberto.
Roberto.
Roberto is So, 68-year-old man with a stage 3C melanoma. So the patients got previous melanoma with a Breslow of 3.7 millimeter on the left lateral side, no tender lymphadenopathy in the left inguinal region, 5 centimeter. The biopsy of resected lesion showed also ulceration, invasive melanoma, high meteoritic rate, and positive margins. As additional findings, the PET scan showed a left inguinal lymphadenopathy without distant metastasis, and the lymph node biopsy confirmed metastatic melanoma. The patient was BRAF wild type. So, is this a patient's candidate for neoadjuvant immunotherapy from your point of view?
Absolutely. I mean, he is a candidate, number one. Should we do it? Yes, unless there is some significant comorbidities in an ECOG of 3 that is not written down. So I think absolutely. I mean, this is, I think, a typical clinically detected lymphadenopathy. So yes, I definitely would discuss with a patient the neoadjuvant immunotherapy approach, and would again provide the data that I know you will go through for the shared decision-making therapy selection.
Yeah, no, I will tell you that as we started this field of neoadjuvant therapy, we were looking for patients for research purposes and say, yeah, let's see what this will look like on a clinical trial. Now with the data, we actually try to find those patients and catch them before they go to surgery, because we can help them with neoadjuvant therapy.
Yeah, so I'd like just to remind you the concept of the neoadjuvant with immunotherapy. You know that the neoadjuvant was born with breast cancer, and at the beginning it was to make resectable and unresectable disease. But with immunotherapy now, what we would like to do is to better immunize the patients, because we have the tumor, we start immunotherapy, we have more T-cell activation, more memory cell, and when we resect the tumor, we have several cells still inside that can help for the action against a possible minimal residual disease. So this is the concept. So, but we know that we have some option, a different option. So we can have the monotherapy, we can have the combination. So from your point of view, how can we select patients for monotherapy or for combination? All the patients should be treated with combination? It's difficult.
So this is, I think, a more difficult discussion because we have data for both. And I know you will go through this. I can maybe share my practice. I think in this assuming fit 68-year-old, I would prefer the combination immunotherapy. I would discuss again the Ipi-Nivo based on the Nadina trial as really something that was, I think, really finally leading to really making this an approach in the field that is optimal. We also need to discuss single agent, but again, I would favor with this large lymph node and again, this ulceration hematotic rate, which probably led to the lymph node, but I would say this is again, somebody that would be treated with double in my practice. And to maybe also looking at the next question, how would this then result in subsequent therapy? And again, there was a question again from the audience is, in most patients, we will take them through surgery. I think only very few patients did not undergo surgical resection or undergo a total lymph node dissection. So I think most patients will have this. And I think it's really important, again, somebody with a 5-centimeter node has a high likelihood of having other sites involved. So when we look for the grade or the depth of pathologic response, I think it is important to capture the other area, in that case, again, the groin. But again, it also will provide us guidance on if we even have to offer adjuvant therapy or not, which again, I think is one of the really incredible advances over the last 2 years or so that we now can omit potentially adjuvant therapy in patients who had a major or complete pathologic response. So again, I think the field is evolving dramatically. I don't know, Hussein, if you had anything else.
I completely agree. I'm going to propose that Paolo goes through the data because we have 10 minutes and all of the answers will be very clear afterwards.
And of course, we will discuss at the end also the possibility to use intralesional compound and also the combination of nivolumab and LAG-3. So just to look to the data at the moment, as Bella and Hussein said, we have two different options, monotherapy and the combination with ipilimumab and nivolumab. We have two trials. One is the SWOG 1801 that compare the neoadjuvant approach with the adjuvant, classical adjuvant surgery, and then pembrolizumab as adjuvant. And the neoadjuvant approach was 3 cycles of pembrolizumab surgery and then the continuing to pembrolizumab for the rest of 11 months. And as you can see, the neoadjuvant showed the superiority compared to the classical adjuvant treatment in terms of event-free survival. It's really, impressive how neoadjuvant was better than the adjuvant. And about the ipilimumab and nivolumab, you know that in the Nadina was used the lower dosage of ipilimumab. Why this? Because there was a previous study, the OPACIN-NEO, where the investigator uses the two schedules, so the high dose of GP and the lower dose. And as you can see, looking to the pathological response, were really similar, 80% compared to 77%. And for this reason, in the Nadina was used the lower dosage of ipilimumab, and more than 1 mg per kg was used the flat dose, not only of nivolumab to 40 milligrams, but even the 80 milligrams of ipilimumab. 2 courses of this combination, then the lymphadenectomy, and then the patients, according to the pathological response, were randomized to just observation in case of a major pathological response, or adjuvant in case of a partial pathological response or no responses. The control arm was the classical lymphadenectomy, so surgery, and then adjuvant. Adjuvant, all in this case with the nivolumab in order to better compare with the other arms, while in the patients who got neoadjuvant, in the group of patients where adjuvant was allowed, the patients could be treated not only with the anti-PD-1, but also with the BRAF and MEK inhibitor in case of BRAF mutation. Having said that, these are the results in terms of event-free survival and distant metastasis-free survival. And again, in the adjuvant arm, the patients were really better compared to the adjuvant. And more, looking to the kind of pathological response, the patients with complete response went really better than the patients with partial response or with no response, as you can see. So about the 95% of patients were still progression-free and also without distant metastasis after more than 1 year, 18 months. So for this reason, when we treat the patients with neoadjuvant, we got pathological complete response. And considering also the near pathological complete, it's about 60% of patients we cannot treat it with adjuvant. So we cannot. We can avoid the adjuvant treatment because these are the group of patients that maintain the response just with the 2 cycles of neoadjuvant. When we discussed with the patient, as Bella said, this is also something that we should discuss. You can get just 2 cycles of neoadjuvant, and then in case of pathological complete response, you cannot be treated with the adjuvant because you can still get the benefit with just these 2 cycles. And there are also other interesting data. These are interesting data from the MD Anderson group with the combination of nivolumab and relatlimab, anti-PD-1 and anti-LAG-3. And as you can see, the number of patients with major pathological response, PAT-CR and near PAT-CR, is again more than 60%, like Ipi/Nivo, with less toxicity. And again, the patients who got major pathological response, looking to the relapse-free survival, the curve is really high and really flat. So these are the patients who don't progress. In this trial, you treated all the patients with adjuvant, if I remember.
Correct.
But still, this may be a group of patients where we probably can avoid adjuvant. So we'll see in the next trial. There is another drug that we should mention because there is another positive trial in the field of neoadjuvant. The pivotal trial with another drug is the Daromon. Daromon is a double fusion protein, so 2 fusion protein that bind the L19, that is fibronectin. The fibronectin is highly expressed in the tumor microenvironment. And on the other side, one protein has IL-2, the other one tumor necrosis factor. So this protein bring IL-2 and TNF in the tumor microenvironment, increasing the number of T cells in tumor microenvironment. It's a locally injected drug, weekly injected for 4 infusion, and just this is neoadjuvant. And in the pivotal trial, this approach showed a better relapse-free survival and also distant metastasis-free survival in the patients treated with the Daromon compared with the control arm, classical surgery, and then follow-up of adjuvant. And at the moment, here in the US, there is a clinical trial ongoing. The name is not Duncan, it's
NeoDream.
NeoDream. It's the NeoDream, so the patients could be treated with this drug.
I have to know it. I think I'm the PI.
Yeah. But I should know as well. But the same. Why this trial? It's interesting because your question could be, but we have pembrolizumab, we have Ipi/Nivo, and then this drug. The 38% of patients enrolled in this study were patients who failed a previous adjuvant with anti-PD-1. So for this reason, this may be a second-line approach with the neoadjuvant. So all the patients who have recurrence in the lymph node or in the skin after a treatment with adjuvant or neoadjuvant can be treated with the drug. So this may be the future. At the moment, we have just this trial and another US trial. We'll see. in the next future. So just as a recap, this is a patient's wild type, and Robert, surely it's a candidate for the neoadjuvant treatment. And we have seen these two possibilities, so to treat with the combination or the single agent. With the combination, probably we can have more pathological complete response, and this may be just the treatment for the patients without any adjuvant treatment. This can be discussed with the patients. If the patients is scary about toxicity, probably we can switch to the SWOG schedule. The pathological response will be in the future the biomarker in order to select the patients for the adjuvant. Of course, we are talking about the patients with the clinical radiological tumoral lymph node. These are the patients who can get the neoadjuvant. And we have seen from the data that it's really highly effective. I will say that because we have very few time. The last question, and think about the evidence from the NADINA study in stage 3 melanoma, and select the statement that match your thought on outcomes with the neoadjuvant nivolumab, ipilimumab in this study. Please vote. Yeah.
Excellent. Yeah, I mean, I have to say, it's really, one of those things that is just such a remarkable approach. The benefit that we see, and the point that you could treat with 2 cycles, not have to do anything, and some of these new agents, like the ability to do these 4 injections and have such a huge impact from the Darmon trial. I mean, that's already a positive phase 3 trial, where you do 4 injections and some of those PD-1 recurrent patients that already been PD-1 treated, and you could get benefits. So we're excited about the neoadjuvant setting, not just because of how many cures we could probably induce in that setting, but also the fact that we can bring in new agents as well. So we're exactly at 8:30, but we've I think it was an engaging enough discussion, and I'll let you finish up, Paolo, and then we'll take maybe 5 more minutes to address some of the questions that came through the chat or any questions in the audience as well.
So just to tell, this is the last slide that you will see in the next days during the melanoma skin cancer session. 2 interesting presentation, one from Ahmad Tarini, the other one from Dr. Moradian about the neoadjuvant, and with so different combination, one with a local injected drug, the vidutolimod, that is a tool-like receptor 9 agonist, and the other one with a combination with anti-PD-1 and anti-TIM3, another checkpoint. So we'll see an interesting data. And Hussein, just remind that we will see also the EORTC study with the encorafenib, binimetinib in the stage 2.
Oh, that's going to
This will be another interesting study to look at.
Wonderful. Thank you so much. Let's address a couple of questions that came through the chat. There was a question about relativity 098 and any thoughts on why PD-1 combinations have not been useful in the adjuvant setting. Paolo, what do you think?
So the adjuvant setting is a different setting from the metastatic. In the metastatic, as you said at the beginning, we have a tumor, and we have the interaction between immune system and tumor. In the adjuvant, we have a possible minimal residual disease. It is different. So at the beginning of the story with anti-PD-1, in the adjuvant, it was not so obvious that was a positive treatment, and at that time, I remember a lot of discussion why an anti-PD-1 should be positive in the adjuvant. Now we know that anti-PD-1 is effective, but I don't believe that in that setting of patients where we have a minimal residual disease, we need of a dual modulation. So probably one is enough. Speaking about checkpoint inhibitor, different question with the vaccine, because with the vaccine we have a different mechanism, and this probably maybe is more effective, but I don't believe we have the example that you mentioned of 915. We know from the press release, the 098, we'll see the data, and also the vibostolimab, the KV, so all the combination failed. So anti-PD-1 probably is just the checkpoint inhibitor that we can use, monotherapy, no more from other checkpoint modulation, but other mechanisms may be good.
Should I grab 2 TIL quickly?
Let's do one more neoadjuvant. That's for you,
Okay.
Bella. So when you're treating neoadjuvant with neoadjuvant ipi-nivo, how often have you seen cases where therapeutic lymph node dissection or subsequent adjuvant therapy have been omitted?
So it's the patients we didn't receive surgery.
Neoadjuvant. Yeah, so you get the neoadjuvant. Do you see patients in which you don't do surgery
Very
for,
few.
or for those that
Very
you end
few.
up-
Very few.
Very
I think
few.
I tried to mention that in the talk because I think it's extremely rare that we don't get to the surgery. Again, very rare to see progression, very rare really omitted due to side effects. So I think the majority of patients still will get through it.
The same about adjuvant, because so far, before the NADINA data, of course, we didn't know about just few data on a small trial. Now we are more confident to don't give adjuvant to patients with the pathological complete response.
And I will have to say that in the neoadjuvant setting, the actual pathologic response, the degree of it is so important and so predictive that you actually need that answer. So as much as you may think, okay, we may be able to omit surgery, all that kind of stuff, surgery itself and that answer from the pathologic response is very critical for prognostication for what to do in the future. So I don't use it to omit either. I did treat one patient who was 97 years old with a very large neck lesion with one dose of single agent PD-1 with the idea that we were still planning on surgery, but then actually had such a good response that obviously he decided not to go. So like you have like these weird cases and you could do that, but that's not the norm. So go ahead, Bella, you could
So I
answer
think
one
there
more
were
question.
just 2 quick TIL questions, maybe. If you can just resect the solitary met and freeze tumor to make TIL later. So just remember, TIL is an active living product. So if you freeze your cells, they're dead or not alive anymore. So no, you cannot do this. You can freeze TIL, or at least we used to do this, and then thaw them and expand them, but no, you can't just do that. And then again, the other question was when we're starting to plan for TIL. So again, you can't really start a patient on BRAF and the next day already, in my mind, put them down for TIL. But I think it is when you're already on BRAF in the stage 4 setting, I think TIL needs to be in the back of your head with a very low threshold, but I don't plan it concurrently, if that makes sense.
Excellent. Any questions from the audience? Go ahead.
So we talk a lot about the combinations, the ipi-nivo and ipirella, or no, nivo-rella.
Yeah.
So, and there it's balance of toxicity and efficacy. And I'm not aware of those two having been compared head to head, or those two combinations
Correct.
having been compared head to head, and they probably won't be. But in terms of how dramatic is the difference, for example, in terms of toxicity between the two combinations, and then the differences in efficacy of the two combinations? Because if one was clearly superior, if one's clearly less toxic and more effective, that would be the one we're using. So how do we make that decision?
So I'm going to ask you a question before I answer one of them. So how big do you feel in your practice the difference between single agent PD-1 and ipi-nivo as a combination in terms of toxicity?
I'd say it's noticeable, but not unmanageable.
Right. No, absolutely. And that's actually the answer. I can tell you that we were running the blinded trial for nivo-rela versus PD-1, and we did the adjuvant blinded trial and the phase 3 blinded trial. And as a very experienced immunotherapy practitioner, so to speak, I never actually was able to find out which was which. So in terms of how you practice, that 10% difference in immune-related adverse events that makes Nivorella more toxic than single agent PD-1. On an individual patient level, it's actually hard to feel. So that's why when I compare, in my mind, they're not very different. Like Nivorella adds just a little bit extra toxicity. Ipi-Nivo is still Ipi-Nivo. So that's the difference in toxicity. Efficacy has not been compared head-to-head, and I agree with you. Unfortunately, it won't be, to my knowledge. But there's been one study that Paolo mentioned where we did the indirect treatment comparison, which was basically a statistical method. It's actually a pretty decent way to do this, between Checkmate 067 and Relativity 047, and you basically take the individual patient data, this is not retrospective, and you basically take the baseline characteristics and you match them, and now you can compare outcomes. Paolo, I thought you could address that. I mean, it was basically pretty close.
No, yes. If you look the curves from this study, it's exactly the same. Anyway, so I believe if I can give an answer, and this is my feeling. So after treating a lot of patients with the combination with Ipi-Nivo, that Ipi in some condition is still better. Which are these conditions? Yeah. We are discussed about asymptomatic brain metastasis, elevated LDH, mucosal melanoma, maybe high tumor burden. So in all these cases, if we have, no concerns about toxicity, I believe that we should prefer Ipi-Nivo.
Now, related follow-on question, really simple one. So someone's had one of the combinations beforehand, they progress. Should we be crossing over to the other combination if we're going to cross over?
So I think the data is maybe more hopeful for response rate if they were Nivorella and then switching over to Ipi-Nivo. I'm expecting a slightly higher, 20-ish, high 20 response rate, and I've seen it. I think if you had Ipi-Nivo and progressed, Nivorella will just not give you the blockbuster benefit, right? So this is, again, for sure a patient that we would love to enroll in a clinical trial before we would consider even BRAF, if they're positive and if they can tolerate doing more IO or setting up for TIL. But I think that's at least my gut feeling, that the Ipi-Nivo in the post-Nivorella still will give me a higher benefit than the other way around.
Yeah.
Thank you.
So we might even go, I think in the second line setting, you heard our first option is still clinical trial, actually, and then you fall back on other things. Well, thank you so much. This was really excellent. Thank you for the audience that is not in the room, and I know there's been a large number that joined online. Thank you for your attention. Paolo and Bella, thank you so much for your presence here and for your expert advice, and thank you, everybody. Have a good night. And peer view, thank you for handling me. Oh, if you did...